think. So I'm honored to present you my presentation about cancer dyspnea management. And first of all, I'd like to thank to Jockey Club Home for Hospice and the Society for promotion of hospice care. And I would like to appreciate my friends, Dr. Foy Won and Jack Leong and Kitty Siu for giving me this great opportunity and our arrangement for this great opportunity. And so let's move my presentation, how to manage cancer dyspnea. And this is the overview of today's my presentation. In first part of my presentation, I will talk about the evaluation of the cancer dyspnea, including the mechanism of the dyspnea development. And then in second part, I will explain the current evidence and the role of palliative treatment for dyspnea in cancer patients. Yesterday, Professor Margaret Campbell presented a similar topic, and some parts are overlapped, but my presentation is more focused on cancer patient, so more specific things inside in my presentation. And so, what is dyspnea? The American Thoracic Society defined dyspnea as a subjective experience of breathing discomfort that consists of qualitatively distinct sensations that vary in intensity. This is a definition of the dyspnea accepted internationally. And the most important things is dyspnea is a subjective symptom. It is not necessarily related to objective parameter such as the low O2 saturation. So why dyspnea is important when we see the cancer patient? First, dyspnea is very frequent in advanced cancer patient. According to the previous reports, more than 50 to 70% of advanced cancer patients develop dyspnea during their disease course. That is very, very frequent percentage. And this figure shows the prevalence trajectory of each symptoms at last months in cancer patient. This is the data from the Yodoga Christianian Hospital and presented by the Professor Tsuneto. And as you can see, dyspnea prevalence increases during the very, very last few weeks of life. So especially within the 2 weeks of life. And another study in terms of intensity of the dyspnea. This is the data from Ontario, Canada. In Ontario, all cancer patients of the designated cancer center input their ESAS score, so symptom score, and palliative performance status score at every outpatient visit. So this data is published in the JCO in 2011. According to this data, intensity of dyspnea also increases. This bar is, this line is a dyspnea. So increases the intensity during the last few weeks of life. So dyspnea is getting increase in both its prevalence and the intensity towards the end of life of the cancer patients. In addition to that, cancer patients who have dyspnea suffer from the poor exercise tolerance, and they showed poor quality of life. And also, having dyspnea is related to the poor prognosis in cancer patients. And this is very important, especially for us healthcare providers, because we have to consider whether it is suitable to undergo or continue disease-modifying treatment or some kinds of invasive procedures when we see the patient developing the dyspnea. I think that may be the time to start end-of-life discussion when patients develop the dyspnea, if you have not started it yet. So let's think about the mechanism of the dyspnea development. So dyspnea is not simple sensation. It's not like a pain. So there are several factors related to dyspnea development. First, chemical stimuli. So low PO2 and high PCO2 will stimulate the chemical receptors. So there are peripheral and central chemical receptors. Peripheral chemical receptors are located in aorta and carotid arteries. And while central receptors is located in the medulla. But these chemical changes cannot thoroughly cause dyspnea. So for example, a chronic respiratory failure patient or a congenital central hypoventilation syndrome patient do not develop the dyspnea in the setting of hypoxemia. Not only the people with such kind of disease, for us healthy people may not develop dyspnea even with low PO2 setting in certain situation. So this right side of figure is from the New England Journal 2007. This figure shows the relationship between the airplane altitude and the SpO2 level of the passenger in airplane cabin. As you can see, on the altitude of 8,000 feet, saturation O2 decreased to around 90 to 91%. But you know, we usually do not develop the dyspnea, especially at rest during our flight. So same things happen when we climb up the high altitude mountain, like Mount Fuji. So we don't feel the dyspnea even in the low saturation at rest in the top of the Mount Fuji. So this means that dyspnea is not equal to the respiratory failure. So, and the respiratory failure does not necessarily cause the dyspnea. So dyspnea is a subjective symptom, and respiratory failure is an objective condition. So we have to separate these two concepts. So sometimes the patient develop the dyspnea without the respiratory failure, and sometimes patients do not develop the patient do not have yeah. Okay. And second factor is mechanical stimuli. There are receptor which sense the respiratory muscle movements and the lung and the airway stretches or pressure in the interstitial area. These stimuli pass through the branches of the cervical and the thoracic spinal cord. About this issue, many researchers have been presented from Japan. So in-phase chest wall vibration, this means IPCWB. This means giving the vibration stimuli to the inspiratory muscle during the inspiratory period. It is shown that this in-phase CWV decreases dyspnea. On the other hand, out-phase chest wall vibration, which is giving vibration stimuli to the inspiratory muscles during expiratory period. This procedure has been shown to worsen the dyspnea in the patient. From these findings, mechanical stimuli have at least some role in developing the dyspnea. So this stimuli is coming up through the thoracic and the cervical spine nerves to the brain. But subject with a high level of spinal cord blockage, for example, by spinal anesthesia or spinal cord injury, can develop the dyspnea. So this means the mechanical stimuli also cannot solely cause the dyspnea. So I have experience of my patient with a high level of cervical spinal cord injury who get the pneumonia and who develop the dyspnea. So this means blockage of this nerve not stop, enable, block the dyspnea. So another factor is brain region where dyspnea-related signals are processed. According to the brain functional imaging study, the area of limbic network, which includes the anterior insular cortex, anterior cingulate cortex, and an amygdala, are activated during the dyspnea. And this area are also activated under the pain settings or emotional burden, such as fear or angers. I think this may explain the relationship between the dyspnea and anxiety, and which I will tell you later. And this slide summarizes the signals related to dyspnea development. Once a respiratory command from the brain goes down, respiratory muscle and the lung responds to that command, and then result in actual mechanical movement, that is the respiration movement, and changes in the chemical parameter, such as the PO2. And these changes are translated to the nerve signals and goes up to the respiratory center in medulla. When respiratory center receives these signals, efferent copy of such stimulation signals are sent to cortex and the limbic system. Then brain recognizes the peripheral response to the central command. And additionally, volitional respiratory command from the brain cortex and the emotional or psychological stimuli from the limbic system have some influence in this process. So at this moment, there is no rigorous conclusion about how dyspnea develops. But the most promising hypothesis is this. If the peripheral respiratory response is adequate to central respiratory command, people do not develop the dyspnea. For example, when we jog the 1 kilometer or 2 kilometer, usually respiratory rate increase 30 or 40. So very tachypneic. But we do not feel dyspnea so much, right? So this is because the response that is increasing the respiratory rate is adequate to the respiratory command. On the other hand, once respiratory activity is not adequately respond to the command, people will develop dyspnea. This is a theory of the command response imbalance. So in addition to this, emotional and psychological things have accessory role in developing the dyspnea. So let's move to the evaluation of the dyspnea in cancer patient. So I always tell my residents when they see the patient with dyspnea, I tell them to evaluate the dyspnea itself and evaluate the dyspnea etiology also. So we usually use item, single item evaluation tool like NRS or BAS for quantitative evaluation of dyspnea. Also, modified MRC scale is used widely in clinical and research setting as a categorical tool. One thing I would like to add about the modified MRC scale, this tool evaluates the functional status related to the dyspnea, not dyspnea itself, so directly. So I think this is a very good tool for the clinical use, but I don't think this tool is suitable for the clinical research for the of the dyspnea. For the evaluation of the dyspnea quality, I always ask the patient whether they feel difficulty in inspiration or expiration. Also, what the character of the dyspnea is like, sometimes very helpful. So is it air hunger? Is it increasing respiratory effort? Or is it the tightness of the chest? So these characters may give some hint for detecting the etiology or underlying pathophysiology of the dyspnea. And the Cancer Dyspnea Scale, CDS, is very comprehensive evaluation tool, which is developed in Japan. So this tool is validated and used also in some Western country like Australia. For the research purpose, St. George Respiratory Questionnaire or Chronic Respiratory Disease Questionnaire can be used, but these tools are mainly focused on the chronic respiratory disease, such as COPD. So, these tools are a little bit complicated. So we rarely use these tools for the cancer patient. So when we evaluate dyspnea etiology, of course, we do the physical examination, including the vital sign check and laboratory test. And if necessary, we order the imaging study. But when we consider laboratory test or imaging study, so patient condition and the patient's value, so they are willing to do the imaging study or other studies or not, should be taken into consideration before we order it. And I would like to say, use available existing data as much as possible, not to give unnecessary burden related to doing the test. And additionally, modifying factors are also evaluated, which includes anxiety or mood. And this table shows exact etiology of the dyspnea in cancer patient. So etiology exists not only in chest cavity, so lung or heart, but also outside of the chest. For example, the restriction of the diaphragm movement by massive ascites or huge hepatomegaly. Also, dyspnea is in cancer patient is sometimes from non-cancer etiology complications, so like pneumonia or underlying heart failure or underlying lung disease or anemia. So we have to check these non-malignant causes also. And Arif Kamal from Duke University said that like a total pain concept, when we see the patient with dyspnea, the view of total dyspnea is very important. So I'd like to say, seeing the patient with dyspnea, we have to see the patient as a whole person. That is always important. So in summary of the evaluation of the dyspnea in cancer patient, dyspnea is subjective symptoms not necessarily related to the objective parameter, and the imbalance between the respiratory command from the brain and the respiratory response of the peripheral is expected mechanism of the dyspnea development. And the concept of the total dyspnea is very important. So we have to evaluate the patient very comprehensively. So let's move to the next part, palliative treatment of the dyspnea in cancer patient. So first, about the oxygen therapy. So we healthcare providers tend to automatically think about giving the oxygen when we see the dyspneic patient, but is it appropriate? So when we think about the oxygen therapy, we have to distinguish hypoxemic or non-hypoxemic patient. This is a study of the hypoxemic cancer patient with dyspnea. Patients were given 5 millimeter per minute of the medical air or oxygen for 5 minutes and crossover. And after giving each gas, BAS score, dyspnea BAS score increased 9.4 in air group and 11 point decreased in oxygen group. So between group difference was 20.5, and this is a significant difference, of course, statistically and clinically also. So there is another study showing the tendency of improving the dyspnea more in oxygen group in the hypoxemic cancer patient. On the other hand, there are several studies evaluating oxygen therapy in non-hypoxemic cancer patient. This is the result of the meta-analysis of these studies. We cannot see any superiority of the oxygen therapy in non-hypoxemic cancer patient in each studies as well as its meta-analysis. So the role of the oxygen therapy. So current evidence shows oxygen has not been proven to have any consistent effect on the sensation of the breathlessness in non-hypoxemic patients. And the recent British Thoracic Society guideline said oxygen is a treatment for the hypoxemia, not breathlessness. So we use oxygen therapy for the treatment of the low O2 setting only. And next, opioids. The opioid is thought to be the mainstream of the palliative treatment for the cancer dyspnea. But at this moment, mechanism of action of opioid for dyspnea is not sure. So hypothetical mechanisms of the opioid for the dyspnea is depressing the excess respiratory drive and depressing the activation of the limbic network. And about the mu receptor in respiratory tract, we know there is a mu receptor in the respiratory tract, and we used to think that this mu receptor in the respiratory tract have some role in managing the dyspnea, but now we have the negative result of the inhalation of the morphine for the management of the dyspnea. So we don't think that this mu receptor in respiratory tract have the big role in managing the dyspnea. So this is the study evaluated the 5 milligram subcutaneous morphine and the placebo. And this is RCT or a crossover RCT. And at baseline, in both groups, dyspnea BAS score about 50. So in placebo, 50.6, and in morphine group, 57.8. And after 45 minutes, 45 minutes after administration of the both medication, although the BAS score didn't change in placebo, so 51.1, but the BAS score decreased to the 25, about, BAS score decreased to 25 in morphine group, so to the 32.8. So which is a statistically significant difference. So there is another similar studies showing the similar result. So the efficacy of the morphine for cancer dyspnea seems to be promising. However, these data are only for the subcutaneous bolus administration of the morphine. So data about the continuous infusion or regular control release preparation of the morphine are still lacking. So this slide shows which opioid are usually used for the dyspnea by Japanese palliative care physicians. So we conduct the questionnaire survey to the all Japanese palliative care specialists. So according to the results, they use oxycodone or hydromorphone in significant number of the case. Here in this slide, I show only the result about the patient with renal insufficiency, but not only in case of renal insufficiency, but also the case already on the regular oxycodone or hydromorphone for the pain control. The palliative care physician in Japan use opioid other than the morphine frequently. So how about the efficacy of the these opioids for the dyspnea? So for oxycodone, evidence is still lacking. This slide shows the result of the retrospective chart review from the one Japanese hospital. So roughly, about the 80% of the case improved the dyspnea after starting or increasing the oxycodone continuous infusion. However, outcome measure used in this study was very, very anecdotal too, which is not validated. And that is research related, so very biased. So obviously, the quality of this study is very, very poor. But this was the only study about oxycodone for the dyspnea. When we developed the clinical guideline of the management of the cancer dyspnea in 2016. So our group conducted the randomized control trial, which compared the efficacy of the oxycodone and the morphine for the dyspnea in cancer patient. So we recruit the cancer patient with dyspnea who have already on the regular oxycodone for the management of the pain. And we randomly assigned to the immediate release morphine group and the immediate release oxycodone groups. This is open label single dose study. And we evaluated the changes of the NRS from the baseline after the 6 minutes and 120 minutes after administration of the study drug. But our study was terminated prematurely due to slow recruitment. We planned sample size as 100 patients in total, but the actual participant number was only 70 patients in 2 years. Yeah. So we could not conclude, but we published the result. So this is the result of our study. Oxycodone may be as effective as the morphine in numerically, but of course, this is not statistically significant. So anyway, so we have to do a more quality study to conclude the efficacy of the oxycodone. So how about the hydromorphone? There is only one study about the hydromorphone for the cancer dyspnea. 25 adult cancer patients from a single institution were enrolled in this 3-arm crossover RCT. The 3 treatment arms are normal saline nebulization, hydromorphone nebulization, and the subcutaneous hydromorphone administration. So 10 minutes after administration, dyspnea intensity in all 3 groups significantly decreased from the baseline, as you can see in this slide. But there is no significant between group difference. So there is no superiority of the hydromorphone compared to the nebulized normal saline. So this is the only study about the hydromorphone at this moment. So talking about the fentanyl, there is several study about the fentanyl for the cancer dyspnea. So this is a study conducted by the Pina from Brazil. He evaluated the oral transmucosal fentanyl in placebo-controlled RCT. They gave OTFC and the placebo before 6 minutes walk test and evaluated dyspnea intensity. But as you can see in this slide, they could not show any statistical significant difference between the 2 groups. Another study was about the subcutaneous fentanyl. This study was not intended to evaluate intergroup difference, but I show you in this slide dyspnea intensity in both groups. The first 6-minute walk test is on no medication, so it's not so meaning. But second work, this is after the giving the study medication. So in fentanyl group, after 6 minutes walk test, the dyspnea NRS increased to 2.5 on average. On the other hand, the placebo group, they increased to 3 in NRS after 6 minutes walk test. So numerically, there is not so much difference between two groups. So after this study, David Huey conducted the 2 more study. One is intranasal fentanyl, and the other is the fentanyl bacal tablet. So only fentanyl bacal tablet showed a small but significant improvement compared to the placebo. But anyway, at this moment, there is no consistent evidence about the fentanyl for the management of the cancer dyspnea. So many healthcare provider has fear of the respiratory depression when using the opioid for the dyspnea, especially to the fragile patient, such as the advanced cancer patient. But this study of the Clemens from Germany showed that we don't have to have such afraid when we use the opioid for the management of dyspnea. This study was conducted in hospice and using morphine or hydromorphone for the management of the dyspnea. In this observational study, after using the most opioid, dyspnea NRS decreased from the 5 to 1 at rest and 7 to 3 on exertion. But we didn't see any significant decrease of the PO2 value, so SO2 value, and increased transcutaneous PCO2 value. So this means that the opioid could bring dyspnea relief without causing the clinically significant respiratory depression. So in summary, systemic morphine for the cancer dyspnea is basically efficacious, but the data of the regular use or continuous administration is still lacking. So we have to evaluate the efficacy of these way of the administration. And the efficacy of the oxycodone and hydromorphone is uncertain, but not rarely used these drugs in Japanese daily practice as an alternative to the morphine in certain settings. So more research is warranted in this field. And how about the efficacy of the fentanyl? The efficacy of the fentanyl is also uncertain. There is still some evidence, but existing evidence is only for the prophylaxis of the exertional dyspnea, and the results are still conflicting. And also in Japan, we rarely use fentanyl for the management of the cancer dyspnea. So then benzodiazepine. So many textbook tells us that the treatment of choice, benzodiazepine as the treatment of choice for the dyspnea in cancer patient. But why we consider benzodiazepine use? So dyspnea may cause or worsen anxiety, and the anxiety worsens the dyspnea. So this is so-called dyspnea anxiety dyspnea cycle, so very vicious cycle. So we expect that benzodiazepine may stop this cycle. So benzodiazepine use for the dyspnea management is based on this hypothesis. But how about the result? So meta-analysis shows the benzodiazepine solo use is not efficacious compared to the placebo or morphine. This is the updated Cochrane review. Professor Campbell showed the previous Cochrane result, but nothing has changed in this updated version of the Cochrane review. So we think the role of the benzodiazepine is in combination use with morphine. So this slide shows the result of a 3-arm RCT done by Navigante. These bars show the proportion of the patients perceived improvement of the dyspnea in morphine solo use and the midazolam solo use and morphine midazolam combination use group. So this black bar is combination use. So in combination group, proportion of improvement is significantly higher than other two groups. But this measurement is not validated tool. And the BAS score in this study was not significantly different between groups. So it's not so high quality evidence at this moment. So at this moment, efficacy of the benzodiazepine solo use is uncertain. And we do not suggest to use the benzodiazepine solely for dyspnea in cancer patient because of lack of evidence. And adding benzodiazepine on regular opioid is possibly effective. But we have to care about the increasing adverse events when we use the benzodiazepine in combination with the morphine or the opioid for very advanced disease, because there is a concern about the adverse events, especially sedation or respiratory depression. So we gathered this evidence and generated the recommendation and published our clinical guideline of the treatment for the cancer dyspnea in 2016 on Journal of Palliative Medicine. And this slide shows the overview of and the algorithm of our cancer dyspnea management clinical guideline. So when we see the patient with dyspnea, first we have to do the comprehensive dyspnea assessment. And if we find that some specific etiology, we have to consider the etiology specific treatment such as corticosteroid for the lymphangitis calciumatosa, SPC syndrome, or major airway obstruction, and or pleural drainage or pleurodesis for the malignant pleural effusion. And after that, we have to evaluate the patient is hypoxemic or not. If the patient have the hypoxemia, we should consider the oxygen therapy. And if the patient do not have hypoxemia or still dyspneic after giving the oxygen, we usually consider the systemic morphine. If the patient is opioid naive, we may consider the codeine or dihydrocodeine if we have some concern about using the morphine. And if the patient have the renal insufficiency, oxycodone may be used as an alternative. And after giving the systemic morphine or as opioid, and still patient dyspneic, we have to consider the benzodiazepine adding on the opioid. So in summary of the palliative treatment for the cancer dyspnea, oxygen is basically only for the dyspnea in hypoxemic cancer patient. So we do not suggest using the oxygen therapy for the cancer patient with dyspnea without hypoxemia. And the morphine is mainstream of the pharmacological therapy for the cancer dyspnea management. And we have to conduct more research of the pharmacological therapy for the cancer dyspnea, such as other opioids other than the morphine or benzodiazepine or steroid also, to improve the cancer dyspnea management. So that's all my presentation, and thank you for your attention. And once again, thank you for inviting me to this great conference. Thank you.